Like birth and death, the first and last panelists today both have physicians in attendance. I'm feeling very well, thank you. Our speaker teaches in the Department of Humanities and Modern Languages at Petrie College of Liberal Arts, Oklahoma City University. He received his medical degree at the University of Saigon, as well as a certificate in international health planning from the Johns Hopkins University and a doctorate from the University of New Mexico. He held various posts in Vietnam in the field of public health and clinical medicine with the Ministry of Health and other institutions. Oxy, if you would.
Thank you. Remember, remembering the Republic of Vietnam after 36 years after its demise, I would like to recall the achievement in the field of public health and underlining the spirit of service as well as the humanitarian nature of South Vietnam. I will go briefly over the backgrounds between the North and the South, a little bit on the health organization under the French, and I focus more on the health realization under the Republic of Vietnam in the last 20 years between 55 to 75. And then also the difficulty and the obstacle that we met during that time. What is known as the 1954 Geneva Accords in Indochina is in fact a set of 3 ceasefire accords. And the one concerning Vietnam temporarily partitioned the country into 2 military zones for the fighting forces to regroup and to, quote-unquote, temporarily administer their respective zone. There was no political settlement exactly, no permanent political settlement achieved at the time. The U.S. regret but would abide to the accords. And of course, the state of Vietnam rejected the conditions as well as they denounced the process. The background difference. Without real political settlement there was no surprise that the 2 Vietnams would embark into different, if not opposite, directions. North Vietnam, who was just a recent winner, took over the northern part of the country. Then he also wanted to unify the country under the communist leadership. In other words, they want to take over South Vietnam. Therefore, it adopted a very aggressive behavior. First, demanded general elections. When it didn't have his way, it's a call for insurrection. It didn't work, so it organized an armed rebellion. And at the end, in 74, 75, it's openly invaded South Vietnam. It stands roll over the demilitarized zones, and that we come to the fall of Saigon. Of course, the fall of Saigon has a lot of myths that one of the distinguished speakers this morning have explained about some of those myths. South Vietnam is a new country then. The Republic was formed in 1955, and Dr. Ngo Vo has mentioned that, explained that. It was devoted more on the pressing goal of self-preservation, on the nation building that Vo has mentioned before. It has to achieve unity within its borders. I mean, try to settle down the 3 sects, military sects. It has to reorganize the army to replace that the irreverent general chief of staff who want to replace the prime minister. It has to create all the new state apparatus an assembly, an constitutional assembly to write a constitution, even to adopt a new national philosophy like the Cần Lao Nhân Vị. From the viewpoint of internal politics, the North continued the class struggle and the land reform initiated a few years ago. Before that, it had shed a lot of tears and blood, and the communist government was ready to sacrifice a couple, 3, 4 generations in order to realize that utopian socialist society. South Vietnam is more concerned about stability and safety, and without going that far to claim for pursuit of happiness, at least there was a genuine humanitarian concern for the wellness, the welfare of the people. And health is supposed to be a facet of wellness, and therefore healthcare improvement is among the goals of South Vietnam. That brings me to talk about the health organization in the 50s. South Vietnam inherited a colonial health system which at the beginning cared mainly for Europeans. As far as for hygiene or sanitation, it was limited to what you call the standard of living in European centers, European quarters, like a clean running water, flush toilet, and clean streets. The people who need help receive only limited first aid, limited primary care, provided by medics with limited training and limited means. Public health is reduced to some mass immunizations, and people had to turn to the traditional healers, whose therapies have been transmitted from generations to generations, but with little base evidence merits. This is a group of graduates from the middle school in Hanoi. The indigenous people get some help from the first aid. Those first aid are left behind for community campaigns, and they were staffed by former Navy nurses. Between the two wars, the First and the Second International War, they built up some hospitals in the bigger cities and some very sophisticated hospitals in Hanoi and in Saigon. As part of our organization, early in the history of the colony, they built up the AMI, which is Assistance Medical Indigène, the Indigenous Medical Assistance, which is a branch of the Navy Health Services. Again, in the 30s, between the two wars, this branch of the Navy Health Service became a truly civilian entity. And then in the 1950s, the care was turned over to the Ministry of Health of the state of Vietnam. For manpower, in 1902, they established the first school of medicine in Hanoi. And in 1907, the first group of graduates, they will call it Médecins Indochinois. It's very similar to medicine in Africa or medicine in other colonies. It's not a full-blown MD. In 1936, it was elevated to the status of Faculty of Medicine, affiliated to the University of Paris. That allowed the graduates to further their studies in France and obtain a full-blown MD degree. And after World War II, a Southern École of Medicine was established in Saigon, and after the partition of the country, it became the Faculty of Medicine and Pharmacy, and I graduated from that school some half century ago. So, as far for general health, there's some improvement. We can see that
from the ratio of physician to patient, 1/45,000 in the 30s to 1/10,000 in the 50s. So that's a big improvement, but still far behind what a ratio was in Europe. Facilities, we have only hospital dispensaries in the large districts, and there are few facilities in the countryside. And activities, again, is mainly to treat the patients, but not to take care of the general population. So, lack of manpower, lack of infrastructure, and use of non-scientific remedies were the characteristic of the health population at the time. So let me go to the main point, the achievement under the Republic of Vietnam. In 1966, Knight Bonner wrote a report for SACEI. The name was Pacification in the rural area. Pacification. And he made a claim that there had not been a continuous long-term health planning due to the political instability and the rapid turnover of the Ministry of Health. And I think that that claim is not substantiated. Knight Bonner also used the province of Quảng Nam in his report as an example. And I happened to be in Quảng Nam at the same period between 64 and 66. So I know that in his report there are a lot of true things, but there are also some points that I disagree with. Because in retrospect, when I look on the long term, in the 20 years from 55 to 75, did not stop in 65, that I can see that the Ministry of Health has continuously, persistently, 4 goals. The number 1 is to build up a large base infrastructure in the rural area. The number 2, to improve the quality of existing central facilities that the French had built, but mainly in the big cities. Number 3 is to integrate those 2 parts in the whole in the one system, an articulate system for the whole country. And number 4, to try for continued quality improvement. And again, looking back in 1975, I can see that we have achieved that in various steps. There are 6 of them. Number 1, to build up a rural health network. Number 2, to improve the quality of central facilities. Number 3 is to build up a bridge system between those 2 ends. Number 4, to train mid-level personnel to staff those new facilities. Number 5, to target specific health problems and to establish 7 basic health services. And number 6, to enhance the efficiency by using the mobility and the supervision and support program. So let me go back to the first one, how to build up a rural health network. Before that, let me go over the administrative division. South Vietnam was divided in 4 tactical areas or regions, 1, 2, 3, and 4. And each tactical region is again divided in small provinces. Like tactical region 1 is composed of 5 provinces and a city. And the provinces are Quảng Trị, Thừa Thiên, Quảng Nam, Quảng Tín, Quảng Ngãi, and the city of Da Nang. Now each province is subdivided in districts. And so Quảng Nam has 9 rural districts, while Da Nang has only 3 districts, but they are urban districts. So the main idea here is to understand that Dam Net is really the basic rural area. That's the bottom of the ladder, administrative ladder. While provinces and Cần Thơ, Ban Liệt Thuận, they are on the central level, and in between there are the districts and the village. And district and village are again in the rural area, but on the upper level, much better equipped, much better organized than Hamlet level. So the Ministry of Health decided to build up a rural health network at the very bottom of the society. So we pick up a guy from the local resident of the Hamlet, give them 1 month training in first aid, and upon graduation, give him a med chest, contain only 13 items like liver alcohol, not to drink, just antiseptic, not for drinking. Okay, and some cotton, some aspirin for fever, some tapping codeine for cold symptoms. That's all, just 13 items. And of course, they have the monthly stipend of $600 a month. And that's from the report of USAID report. Yeah, the name is Rural Pacification in Vietnam in 1966. What the philosophy of that rural health network? By putting a rural health worker in the hamlet, you want, number one, to immediately improve the local care, providing basic first aid. On the longer range is to gradually introduce Western and scientific medicine to the people who have so far known only traditional remedies. Number three, in the long term, using those rural health workers as point of access, point of entry in the health system. And of course, number four, on the political stand, to assert the nationalist government presence in the countryside. Of course, with 1 month training, we don't expect a lot of those rural health workers. So their skill, diagnostic skill, and treatment skills are used to symptom recognition and symptom treatments. And so this is the typical report of those rural health workers. They lump all their encounters into 5 headings: emergencies, skin disease, cold and cough, digestive symptoms, and others. So it's very vague heading the symptoms that we can help treat.
What is the source of this table?
Okay, this is come from the statistical book of the Ministry of Health. The last one available was in 1973, because the country collapsed in 75, and those statistical report is later 2 or 3 years later. So what I have now is what I had with me, I brought with me at the time in 1973.
So it is,
Vietnamese health statistic report.
It's also contained in the annual statistic volume which was put out from the 1920s, I believe, through 73 or 74, and you find those in the Library of Congress.
put out by
Well, by various ministries, but each ministry contributed a chapter or a section to it. It's a compilation, so you'll find all the national data.
Okay, thank you.
So by 1973, we had about up and down, but about 3,000 villages. Now, in a small hamlet, they have the facility, we call it the Hamlet Health Station, or otherwise we call it Hamlet Milk Chest. And the rural health worker will keep that in his home or her home. Then we also try to improve the quality of the central facilities. This is an example, is the maternity Hùng Vương in Saigon. It was turned over to the Ministry of Health in 1957. At the time, it had about 60 maternity beds. A year later, we multiplied the bed number to 180, 3 times. 10 years later, we make it OBGYN hospital with 300 beds, and not only maternity but also GYN beds. So it really became a hospital, a woman hospital, even with a family planning center. And by 1975, it has almost 380 beds, which is 7 times than when we received it some 18 years before that. Another example is the Chiang General Hospital. It was built in 1909, improved in 1939, and completely rebuilt in 1974 with Japanese assistance. This is the typical of a provincial hospital. There are hospitals in each province in South Vietnam, but the number of beds varies from 20 to 60 depending on the size of the province. And it has mainly 2 wards, one for medical treatment and one for delivery and maternity. There was no surgical capacity, so we add on the surgical block, and then we have to recruit surgeons who can perform in those surgical. But the main thing I want to mention is that we add on the Bureau of Public Health at the provincial level that would coordinate the care in the rural area. But soon we realized that our goal of introducing Western medicine is really get a good response, and Western medicine has gained acceptance. But by that time, we realized that the training of the rural health workers is completely not up to date anymore. So we need to build up a bridge system. Now, let me go back here to the provincial, which is considered central, and the hamlet in red there, that's really rural. And then intermediary, we have the district and the village. So we build up district, hospital, maternity. We build up village, dispensary, maternity. The district level facility usually had 8 beds, 4 beds for maternity, 2 beds for sick patients, and 2 swing beds that can be used depending on what the need is. At the village level, we sometimes have a hospital maternity with 4 beds, but usually it's just a maternity. And medical treatment is more on the outpatient basis. It's an outpatient clinic. We call it the dispensary maternity and not the hospital. And of course, we have refresher courses for rural health workers because 1 month of first aid training is really not enough for that. Then a pattern of supervision and support developed between those facilities with the district level helping the village level helping the rural workers. But at the same time, there's another referral pattern that took shape in the reverse direction, that is from the hamlet to the village to the province, district to the provincial levels. And so the system became a national system, an expanded system, and the patient would travel freely from the hamlet to the village, to the district, or to the provincial hospital, depending on the needs of the case. This is a village dispensary maternity. Okay, with those new facilities, we need more personnel to staff them, and we have a shortage of physicians. We have only 1 medical school. Each year we form about between 100 in at my time and 200 a year. But every male physician who graduated would be drafted by the army to serve probably about 1 over 40 population, because the military is about 1 million and we have about the military is about 500,000 with the families represent only like one third or one less than more than 1/20th of the population, and they have all the physicians. So we didn't have enough physicians, and we turned to our WHO, the World Health Organization, and they suggested to train the mid-level professional, and what they call it the physician long arms. So we train them. We train the technicians and we train the assistant technician. Technicians have 11 years or high school And then after that, 3 years of professional training. We're training in nursing, which as a nurse now, is also national midwife to do the delivery. But there's a new branch, the public health technician. They are trained to care for the population, not necessarily for the patients. But of course, he had to learn some nursing tricks in case that he needs to care for the patient. But the nursing technician and the national midwife also have to learn some public health, some basic knowledge. And right here I can thank my colleague, Mrs. Min Châu, who has helped us train a lot of the midwife technician. And thank you. They did a good job for me. And then we have also the assistant technician who has only 7 years of schooling plus 1 year of professional training. And so we start the technician at the district level and the assistant at the village level. And they keep on supporting and supervising to the hamlet. By 1972, 1/4 of the personnel of the Ministry of Health are rural health workers working in the countryside. 1/3 of the personnel are technicians and assistants. We have only 2.2 physicians. And how they can function that? Because the physician assist, supervise and support the technician supporting the assistant clinician. So this is you see that the physician is such a small 2% there. But of course, at the same time, we have to take care of the urgent problem, urgent health problem. And they are TB, they are malaria, they are Hansen, which is leprosy disease. There's the problem of health for mother and children. There are some problems with nutrition of your poor country. And we have a school health program. Because at the same time, the government of Vietnam also multiplied the number of schools. So we have the school health program. So to target those health problems, we form program, try to control or to eradicate what it can do. And then also, upon recommendation of WHO, we established the 7 basic health services. What are they? Number 1 is administration and statistics that we ignored in the past. But now you understand that you cannot do anything good, you cannot do a thorough job without the statistics. So that's one service that we established. Then number 2, 3, medical nursing as traditional health care in the past to treat the patient, to care for the patient. Then we established also the 4 new services: MCH, maternal child health, preventive medicine, sanitation, and health education. Those 4 services are compiled in the Directorate of Public Health. So with those established, when we establish those 7 basic health services, we reorganize the Ministry of Health. This is the organizational chart of the Ministry of Health. On the upper part is the leadership, technical and political leadership. On the left side is the administration, is the support, and the right side is the real, is us, the people who really hand-on work on the public health services. And this is a simplified schema. And you can see the Ministry of Health, the leadership on the top, on the right, left side is the administration, and the General Directorate of Health is in charge, and it has 2 main areas: Director of Preventive Medicine and Directorate of Public Health. Now, the Directorate of Public Health includes those 4 new services: public hygiene, which is sanitation; preventive medicine, which was used to be the infectious disease; health education; and the maternal child health. Those 4 services were responsible for the quality of care. So they go and look for the quality. But there's a branch there we call the Bureau of Rural Health Support. And there's a team of rural health surveyors. They are the one who go and look to help. So they are the one who look after the implementation of the programs, while the services look after the quality of those programs. Okay, number 6 step, the last step is the reinforcement by mobility and support program. What's mobility? When we have mobility team, the mobility from the Central District go to the hamlet, but also very important is the mobility team from the central, they go down to the provinces, to the district, and support and control them. But more important is the mobility of the grassroots teams. They go from the district to the village and to the hamlets. Now we come back to the rural health workers, the local guy in the hamlet. They become the health antennas. They know who among the local inhabitants would need some special care. Like they don't know who are one the pregnant woman who wouldn't benefit a service of the midwife, who has TB or leprosy that would benefit from the services of the ID nurse, the infectious disease nurse. So the rural health worker would guide various members of the mobility team to make house calls and to treat those people. So appropriate care to specific cases. So mobility health team are an arm of public health providing continuous care and interval follow-ups. Of course, we have a lot of obstacles. The first one is war. As in any war, those health facilities are what you call now collateral damage. But some of them are not collateral. They are the prime target because sometimes the enemy want to grab the medical supply. The second thing is the distortion in the psychosocial warfare. And we know those warfare sometimes turn into myth. And so I'm glad that the English speaker has talked about those myths. I just gave you some example. I mentioned to you about the rural health worker, which is an antenna in the hamlet, who knows who's sick and who's sick. They claim that that's a population control. Now, I was in charge of malaria at one time. I tried to go and spray the houses, an insecticide, and I made a map. This one has been sprayed, and I put the date, and then 3 months of sick malaria, I correct, okay, second spray. They say that's mapping for military purposes. That's the psychological war. And in response to that, we use health education not only to teach the good practice, but also to disinform, those psychological war. The manpower shortage, I mentioned already the use of the mid-level, but we also bargain with the military authorities to share the physician. So there are 2 programs. One is a joint program where a surgeon stationed in the city would spend half time to serve in the civilian hospital. That's the joint program. Then another program is that someone that we need very bad, we ask them to put it on loan to the Ministry of Health. And myself was a military surgeon put on loan, and so in 1975 I served at the Ministry of Health, but I was legally still an officer of the Army. Another thing, I go back to the claim that U.S. report say that there's no planning. And in fact, we didn't have a lot of planning at the time. But every year we sent a couple of guys to Johns Hopkins to familiarize himself with health planning. And by 1975, we had an embryo planning unit of 16 persons, and I'm one of those. So we did have at the end planning unit. And looking from that viewpoint of the health planner, I can see the long plan that we had. But of course, the big one is in the budget limitation, the aid cut and things like that. Okay, you look at the budget of Vietnam. You cannot see very well, but I can tell you that the budget increased 3.5 times. And the last line, that's the budget of Ministry of Health. Now, increasing 3.54 looks pretty good. However, the budget of the nation, which is the upper line, increased 5 times. So the national increased 5 times, but Ministry of Health increased only 3.5 times. So if you look at the ratio, and you see that the ratio is down. So the budget of the Ministry of Health was 3%. At the beginning of the year, it came down to 2%, which is a decrease of 30%. What does it mean? That means that the war effort led to the decrease of expenditure for healthcare. Now, within the Ministry of Health only, that decrease is not divided equally. We see that the number. Just ignore the line number 1. Look at the line number 2. That's go up. We are in the decrease ratio of the budget, but that one goes up. And that's the direct rate of logistics to buy the equipment, the medicine. And the budget for rural health is down. What does it mean? That means that the buying power is down. So we spend more money for the supply and we have less for the rural health. In conclusion, what we have achieved, the regulator of Vietnam, under the government, has been able to build up an articulate healthcare delivery system with a large base in the rural area at hamlet level, supervised and assisted by the intermediate level in the district and the village, and then supported strongly by the good regional central facilities. We have achieved that at the Republic of Vietnam for 20 years. And those work came in spite of numerous kind of insurmountable obstacles. What happened after 1975? The behavior. I had to think of the behavior of Bhuti by the victors. They came down to the south, they went into the hospital, they took out all those equipment, and they took back in the north. That's the one, Bhuti. The manpower shortage. Most of the physicians, as mentioned to you, were in the military. So those physicians spend their time in the concentration camps. They call it a re-education camp, but it's really a concentration camp. Some 2 years, some 15 years, one is even 17 years. And when they are out of the camps, what do? They join the boat people. They went abroad. So that's the brain system. And the worst thing, I think, is the communist cronyism. There's a misspelling there. The communist nepotism, party favoritism. They said that Hengqian, that means where which is communist, is referred to expertise. No, expert is technical, expert doesn't count. The main thing is party membership. Then also the policy change. I mentioned to you that when we send the rural health workers to the hamlet, we try to accustom people with the good Western medicine, proven. Now there's a push for alternative treatment. Why? For the cost purposes. So we raise this to the quality because we are promotion therapies with low evidence-based proof. Another thing is the cost shifted toward the people. Before the Ministry of Health, in the spirit of service and with the humanitarian concern, provide those care mainly free. In my hospital in Quang Nam, we have only 10% of the beds are paying and 90% of the beds are free. So now there are cost shifting for the people. You have to pay for that. and the pay is more expensive. And you know the. So the quality care, I think that still exists in Vietnam. I know that still exists, but it's mainly for the few. While for the mass, there's poor access and poor quality. And that's why we have a lot of NGO critical teams. Actually, the one that I can think of is the Operation Smile. They go in and fix those malformations and the lips of the hair. So after 20 years, we have achieved a lot. But in the past 30 years, we as Vietnam also have destroyed a lot. So I think that it's kind of, it could be interesting, but it also could be sad to think how social medicine is working in a country that calls itself socialist. Thank you.
We have a bit of time for questions. I just want to comment, though, that while it was stated that most of the French medical practitioners in Vietnam during the colonial period ministered to French citizens, there was enough surplus in the system to help out during the critical doctor shortage during World War I. When the 19 battalions were being organized to send to the Western Front in 1916, the Governor General recalled all retired doctors in the colony, and they were able to staff the battalion surgical units for all the units that went to Western Europe, and actually two that went to the east, to the Balkans, where they fought the Bulgarians, and also to staff a hospital for Vietnamese in Marseille, where the 50,000 Vietnamese troops in Europe, as well as almost an equal number of government laborers who came to work in munitions and other plants in Europe were treated. So French doctors did help the Vietnamese during that critical period of World War I, when there were serious medical shortages throughout the whole course of the war, and helped particularly with tropical medicine, and the fact that large numbers of the Vietnamese arrived in Frizes and San Rafael for training before they were sent to the trenches or to other duties in France, were suffering from a lot of cases of typhoid. Anyway, questions from the audience. Yes, Dr. Sawyer.
Sir, you spoke about traditional medicine. I wonder if you could talk about that a little bit. Tell us what it was like and who administered it and how they learned it and so on.
The traditional healers also called sometimes Oriental medical doctor, and there's no official school for that. It may be from teacher to student on an individual basis, or in the family, from father to son. They are not only healers, they are also masters of feng shui. So if you're in your life, you get along well, either you meet your wife, or you can ask him to come in. You look at the house that the door is too big, that's why the bad spirit come in. So maybe you better narrow up the front door, or put a small tree in front of the door on the east side, and that tree should be big and put a smaller door, a tree on the left, on the right side should be smaller, so that the influence of positive influence of the male would dominate the bad spirit of the woman, so that there will be more peace in the house. So those are the master of feng shui. But they are also what you call geomancy. I don't know what the there's such a word in English or not. Geomancy in French is the guy who is specialized in finding the good spot to bury your owner or your parents. If you get the right spot, the family and the descendant will be successful in life. So that's very important, geometry. Those guys who could do that. So they combine three things: geometry, muscle function, and treating the bad spirit. So they do have some good practices. And I would say that they have good practices, but it is not uniform. It's not consistent, and there's no real control. And there's no license. So if you come early, you can get help. If you come too late, then they cannot help you and you die anyway. But if you come early, they can help you. And just like the Western physician, if you are sick and they give you treatment, you get better in 3 days, otherwise, no physician is better help. So that's how the traditional might help too.
Yes,
Yes,
ma'am.
Do you know, Doctor, if any of these traditional folk remedies have been recorded? Because many traditional remedies do actually have a basis in science that they are effective. Has anything been written like that? And do you have any sorts of knowledge about the past 36 years in health in Vietnam?
No, I do not. What I know is that they do have a school for young. Okay. I think that what is that they do have school of ancient medicine now, but I don't know much about it. I don't think that it is scientific in the way that it's rational. Okay, if it's rational. That's it. If you think it's scientific, it's rational. Yes, it's rational. But the evidence proof, I don't have it. Okay, so it's rational is that bad means and good means, and positive effect and negative effect, which is it's more like a philosophy, philosophical reasoning system rather than just a system.
Yes, sir.
Do you know during the war, which side is bearing the burden of treating the civilian casualty of war? Are the Vietnamese civilian treated in military hospital mostly, or in civilian public health facility?
I guess I cannot answer for sure, but I think that mainly the civilian hospital who took care of the civilian patients. But of course, in some few cases or very difficult cases, that we do cooperate, so we do help each other. But I think in the scheme of things, I think that the civilian hospital who took care of the more.
I was just going to say, based on my own observations over a couple of years, I would say a lot depended on whether you were in a rural or in an urban setting. And certainly in the urban setting, the civilian hospitals seem to be the most prevalent. Anyone else? Yes, in the back.
When I got to Saigon in October 1970, they were having the International Plague Conference, the ballroom above our room. Vietnam had been one of the 3 countries that actually had the plague as one of the more serious illnesses. My question would be is, do you know anything about the losses of medical personnel in terms of doctors, especially during the Way Massacre, to people who went out into provincial clinics? How many of those were killed or kidnapped by the communists? I think they were some of the unsung heroes of the government's attempt to go out and reach the people, and I don't think their stories have been told.
Are you talking about now or then?
Back then, in the 60s, 75.
Okay, I tell you my personal story. I wasn't trained as a surgeon. I did do surgery during my residency, but I'm not a trained surgeon. So the first day when I got the responsibility of taking care of the hospital, the Hogan Hospital, which is about 30 kilometers from Da Nang, 25 kilometers from Da Nang. And On the same day, I had a little boy who had been hit by a buffalo. So the epidural come out to the whole skin like that. So I sent him to Hainan. I made the paper. I'm not going to be taken to Hainan. It's about 5 p.m. So I'm around, and I come back to my office, and the ambulance is in there, the patient is in there, the driver is there, the nurse supposed to accompany is there. Who was there? I asked my wife, that, a week, 2 weeks before you came here, the ambulance has been stopped by the police one time. And he said that we will there, if you get audio again, we will go on ambulance. So there I was non-surgeon in the hospital with a surgical block, but it hasn't been opened at all. So I looked at the hospital, I asked him, the surgical block is there. We act on, and I mentioned about we act on the surgical block, but we didn't have any surgeon there. But I was the only surgeon at the time, the only doctor at the time. So I asked them to open the surgery suite, and there's no sterilizer. So what did I do? I had to boil the water, or put instrument there, boiling it, and use the mask for anesthesia and try to fix that. So the point is that when you transporting the patient is even risky. So that's why we try to improve the surgical capacity of those hospitals.
You have to tell us how that turned out.
It was okay, I was lucky there. And I got the enough.
The kid didn't bring a malpractice suit? No.
We didn't have any lawyers.
I didn't work in business.
And could you comment on the U.S. civilian physician and military physician volunteer to come together, risking their life, to help the Vietnamese people? You hardly know some of them or a lot of them. Thank you.
At the time, I didn't know many volunteer physicians, but I did have, at the end of my tour in Vietnam, I had the help of a MILPHAP, M-I-L-P-H-A-P, which is the military public health assistance. So there's a group of 3 physicians, one Malaysia, who is a OBGYN, which is good, and 2 young captains. They are very helpful, they want to learn, they haven't did surgery at all, so they know surgery with us at the hospital there. And you think now it's scary. But at the time, I was really pleased to be able to be captain, get out of school, instead of residency, when to work with us. So we appreciate all the help of those physicians. Yes.
I think I can answer your question. I got lucky looking back to Lloyd in the end of October 1970 November. And that is an American doctor, Dr. Silsky, who was an American Medical Association volunteer being for 6 months as part of their program. Sent over to just teach the doctors to help out and stuff. So it wasn't an American aid program on the private sector. And I just have to lucky to get there, but I understand that there were quite a few Americans who came over and developed it also as nurses, and then many of the nurses in the military also helped out. Somebody else is going to tell you that I was doing teaching development. I don't remember exactly where I was. In the Congress Party graveyard in the building I have to be at. And one of my questions, I had to ask the people I was interviewing non-political questions, because I still don't interpret it with my friends of mine. But people were not going to say, oh, we hate the government because they do this and that. So I had to ask, what did the government do for you to say, for that time, that you felt helped you? Education was a big one. The children were going to school. In one case, one said the Vietnam used to tax their pigs. About 500 Oscars did not tax their pig. And also, we now have a medical clinic at the district level, or less, where we said that when a woman went to labor, they have to put her in a boat to take her off to the provincial hospital far away. That was, from the woman's perspective, was one of the most important contributions that the government had made in reaching down into, and it went from provincial level to district level, not quite to Hamlet yet, they might have been visiting the medics come in, but there was an improvement. And this is because, I think that the U.S. stopped these operations in Cambodia in the spring of 1970, pushed Congress so far back into Cambodia and out of the Delta that they gave the government a chance to move in with revolutionary intelligence teams and medical teams and educational administrative teams. And they were able to build these. And as the war had gone different, I think what we talk about here, nationwide system of linking major medical systems down to the lower level that actually takes place. The spirit was there, the drive was there, and the need was there. And that was one of the probably the most positive contributions that the central government Saigon was making with people out there. I think, like I said, it's the whole story. This whole medical aspect of what the Allies were doing, but then the South that we were doing.
I really appreciate what the foreigners invest and also other countries appreciate because we help us. But I am more in charge of the rural health, which is a country level. So I do not have a lot of contact or the knowledge about the things happening in big cities and hospitals. But when I think that those volunteers will have more on the quality rather than on the quantity. The quality, I mean, they help universities and hospitals, so they bring up the quality of those institutions. But they did not have a lot on the coverage in the hamlet and village because those Western physicians wouldn't stay in the village in the hamlet like I had to do. So increasing the coverage, we depend on our local persons. And for the quality and supply, then that's where the foreign volunteers and doctors will be to help a lot.
On the subject of foreign medical assistance, I think it's important to point out that there are a number of nations who were reluctant or were constrained by their own parliaments and legislatures from providing military assistance to South Vietnam, but many who sent not just medical supplies but medical teams. And the ones that I recall in particular were the German hospital ship Helgograd, which came into Saigon and performed a miraculous number of life-saving surgeries or whatever over a specific period of time. The Philippine Civic Action Group, which basically ran, I think, a very large hospital and medical facility in Phu Quoc province. And one group that I met through the University of Saigon, where I taught part-time, were a group of hand surgeons, reconstructive surgeons from Canada. And these were all physicians with practices, very wealthy men, but they all gave 3 months every year to come into Saigon and to do reconstructive surgery, largely on children who picked up munitions or handled something that deformed their hands, and did, really just tremendous work in doing the type of surgery that was beyond the scope of the Vietnamese medical system to handle. And they did it gratis. They paid their own way over. They supported themselves during months they were in country. And I think there were a lot of people who did that, and they're sort of unsung and little known, but I think made a significant dent in the health needs of South Vietnam. Sir?
Yes. I remember I was a child, in the war. But one picture that's sticking in my mind is that this time is the Viet Cong soldier who has a mortar planted in his side. And I think it took 3 physicians. One is the military anesthesiologist, the Vietnamese, and one is like a general surgeon, who's the military, the U.S. surgeon and orthopedic surgeon, so military. And the 3 of them had to build like sandbags around the Vietnam, and then they operate on him to save his life. And to me, that means the big difference between us and them, Congress and Vietcong. Because if it were the other way around, Australia would be left there to die. Nobody would risk their life, to save the soldier from the other side. Only us, would do that.
I think that impressed the enemy quite a bit. My one anecdote, I was in the first Cav hospital, and they had to interview North Vietnamese prisoners of war, and chained to a bed was a North Vietnamese sergeant who was so delighted he didn't want to answer any questions that my interviewers put to him over this 2-hour protocol of questions on sort of psychological survey. He just kept wanting to point out to me, alongside his bed, this large jar of alcohol which had a tapeworm that had been removed from him after he was wounded and captured, which was almost the size of a boa constrictor. I'd never seen anything quite that large. But he was so proud of it that he'd grown this thing, and the doctors, American doctors, had removed it from him, that he kept it as a trophy alongside of his bed. So I think that was one way to impress the enemy, was to give them decent medical care. Sir.
I just would like to share some of my experience on the question of what was talking about the traditional training, things like that. I had been interested in that area because actually that is one of the rising things in the U.S. being called here, so-called the complementary and alternative medicine. But including the homeopathic, naturopathic, acupuncture, qigong, all the kind of things that belong to this so-called alternative. If I have time, I can talk a little bit more. What's the definition of so-called conventional medicine and what is the alternative medicine? But back to the question. I think that the traditional in Vietnam, alongside with this Western medicine, and we have so-called traditional medicine, which consists of herbal medicine. Some of the herbal medicine are influenced by the Chinese medicine, but we do have some of the things that originate from our own experience, and also some other procedures like acupuncture, or they call it cupping, that the suction, the cupping like that, or the cutting. It is just something to release the wind of the toxic substance. Like making it a small cutting like that. And I have to say that it's not like no evidence based. I would say that probably it doesn't have any control study or double-blind control study, but it does have good evidence because that is why people come to me back. And if you remember one of the famous bone doctor who's up, he's one of the bone doctors. All the people with fracture, bone fracture, with some traditional medicine and the plasma. And I was young at the time, and I didn't believe those things because I was trained from Western medicine. But I can remember that I haven't seen anybody that did not come back and function. And from the public health standpoint, probably we are more concerned about the mass preventive medicine rather than trying to be unique in most expensive treatment for one person or something like that. And I don't know what the current system in Vietnam, what the health policy, things like that. I know that from the technical point of view, they do have very advanced things that like cyber knife, things like that, MRI, things like that. But certainly they cannot apply that for mass of very poor people. So I think we still somehow, if they know that they have to promote some of the effective way of traditional medicine to help us before we can deliver some modern medicine to help people. But people need to get up now. We cannot wait until they have their MRI to give them the fracture. But in here, if you have any interest in those alternative medicine, you can go to the NIH website, NCCAM, CAM, you will see they yeah. Not I'm sorry. Thank you. They do have trying to collect all the evidence about those so-called alternatives. For example, you want to know the qigong has anything to do with the hepatitis